Good morning, everybody, and thanks, Dr. Pavlovich, and for inviting me to this wonderful meeting. It's my first time in Serbia, and warm hospitality. And during the past 2 days, I think I enjoyed all the dishes from Belgrade. So it's quite impressive to me. All these doctors are coming from even from the other countries for this balance meeting. So in the morning, I'm gonna present what we have achieved in the area of vascular vertigo over the past decades. So I'm gonna stick to basics because most of you are from ENT clinics. So until the mid-19th centuries, when Prosper Maniers proposed that the vertigo comes from the inner ear, not from the brain. Until then, so even sometime after then, the vertigo had been ascribed to the congestion of the brain. So at that time, the main therapy was trepanation, or letting the blood out as quickly as possible. But after the establishment of vascular physiology in late 19th century by Joseph Brewer, and the clinical neurotology by Robert Barney in late 19th century or early 20th century, the management of vertigo went into the hand of ENT doctors. And after then, few neurologists have any interest in the management of vertigo. And furthermore, the medical adage at that time was that the isolated vertigo never comes from brain. So when the vertigo occurs in central disorders, it almost always accompanies other signs, symptoms of neurological disorders. So that also applies to the vascular vertigo. So this is the first systematic statement on the vascular vertigo by the Professor Miller Fisher, famous neurologist and neuropathologist, and also a stroke specialist in Boston in 1967. And he, in this seminar paper, he made several very important statements about the vascular vertigo. And he concluded that, if you see here, isolated dizziness doesn't come from the strokes. And so he recommends just wait and see whether the stroke develops in the patient with isolated vertigo. So that was the view at the time. And then we should think about that the isolated the vascular dizziness or vertigo is so a rare phenomenon in strokes. But of interest, if you look at the paper, he also stated that about 25% of the patients with posterior circulation stroke have dizziness as the first and isolated symptoms. So it's huge numbers. About 1 in 4 of the patient with posterior circulation stroke present isolated vertigo. But nobody paid attention to this statement. They just remember that no, isolated vertigo never comes from a stroke, so we don't need to worry about the vascular problems. But that's not true. So this is the paper, I believe, the first paper that drew attention to the isolated vertigo in cerebrovascular disorder, especially in cerebellar infarction, is by my colleague in Korea. And he found that more than 50%, 15% in this study, 16.3% of the patients with pica infarction, the inferior cerebellar infarction, actually presented isolated vertigo. So this is the first paper, a very important paper that makes this kind of the vascular vertigo as the key issue of neurology over the past decade. We also extended this study all the patients with posterior circulation stroke, and we found that about 20% of the patients with posterior circulation stroke present isolated vertigo, usually when the lesions are located in the inferior cerebellum or in the medulla. Of interest, Dr. Miller-Fisher also noticed at that time by reviewing the previous papers. So, the vertigo is isolated in about 10% of the patients with a stroke, even at that time. So the diagnosis only based on the pathology and the constellation of the symptoms. So we can expect that this proportion would increase if we introduce the recent imaging techniques. Then why do we bother with this vascular vertigo if we can just wait and see what happens? I will introduce this young man, 56-year-old man, whom I saw about 15 years ago when I started my professional career as a neurologist after fellowship in the United States. Just come back to Korea, and about at the time, I got a call in the night from the emergency doctor at the time. So Professor Kim, there's a patient with isolated vertigo, nothing else. And I examined all, but nothing else. So I'm going to make the outpatient arrangement for your clinic. So it's okay. So just wait. What about the nystagmus? I asked. No nystagmus. Then what about the balance? Well, he can't stand. So just wait. I will see the patient. And at that time, I drove to the hospital right away. It took about 20 minutes at that time. And when I saw the patients, he showed this funny nystagmus. There is no spontaneous nystagmus in the primary position, but when lateral gazes, he shows left beating during the rightward gaze and kind of a torsional nystagmus that can't be explained by peripheral disorder and also severe imbalance. So I scanned him. At the time, MRI wasn't available during the night time, so I only could scan him with brain CT, and it was normal. But, does she have stroke? Does she have stroke? Yes, because the findings cannot be explained by the peripheral disorders. So I admitted him to emergency, intensive care units, and next day I scanned him with MRI and found the infarction, acute infarction in the medial pica territory. Next day, he became deteriorated and less responsive. So I followed up this brain CT, and you can see the hemorrhage here. There have been the hemorrhage conversion during the days and compressing the brainstem. So we decide to decompensate the infarcted tissues. And unfortunately, he passed away due to complication of infection from this surgery. So this is a very tragic story. So at that time, we don't have much for the patient with acute stroke. We just wait with some fluid, with some aspirins, and nothing else. But these days, the management of acute stroke has been changed dramatically. So now the early intervention is very important. The time is gold. So when you see the patients during the acute period, we have many things to do. So angiography, IV thrombolysis, IA thrombolysis, and the hypothermia. We have now many tools to intervene the patient to prevent further progression to save the brain at risk. So early diagnosis is very important in vascular vertigo. Please remember that. Then, what about the small strokes in the posterior circulation that cause a vertigo? Is it so dangerous? This is a recent paper by David Newman Tucker, and he reported small strokes, kind of pinpoint strokes that caused a severe vertigo, and they found that non-lacunar mechanism in about half of the patients. So this indicates that the mechanism of strokes does not differ between the patient with isolated vertigo from small infarction and those with ordinary posterior circulation infarction. So we should treat them with same the protocol. So that is very important issue, and you can see also these small infarction located in the caudal, mostly caudal portion of the cerebellum and in the medulla. Then, how can we diagnose this isolated vertigo in this era of the brain imaging? So are the MRI almighty to detect the vascular vertigo? The answer is no. Unfortunately, even the diffusion-weighted MRI cannot detect the acute infarction in about 10 to 20% of the patients. So if you see these patients from our study, complete normal imaging during the first 1 or 2 days, but later the follow-up MRIs clearly shows the infarction in the medulla or cerebellum. So please remember that the MRI doesn't tell you everything about the strokes. So if the MRI shows something, that's okay. But even when the MRI shows nothing, you still should suspect or consider the possibility of strokes when the symptoms are consistent with strokes. So in the paper that I mentioned before, one of my colleagues found this kind of signs in the patient with isolated vertigo from the cerebellar infarctions. The head impulse test at that time was invariably normal in these patients. It's very important, findings. But if you can see, this spontaneous nystagmus was observed in less than half of the patients, and gauge-evoked nystagmus less more, and severe imbalance in about half of the patients. So according to the traditional view, the patterns of spontaneous nystagmus doesn't help much in diagnosing these patients, because this patient shows mostly horizontal nystagmus mimicking the peripheral spontaneous nystagmus. So this finding clearly shows that a single science, a single test doesn't guarantee the detection of central lesions in the patient with vascular vertigo. So you should combine several tests, several findings to detect central lesions. And this is the paper we reported several years ago on the patterns of spontaneous nystagmus in the patient with cerebellar infarction. So spontaneous nystagmus is observed in only about 1/3 of the patients, and it's mostly horizontal beating to the lesion side. So the patterns doesn't help much. Then what should we do to detect the vascular vertigo? And this study first explored that kind of concept, and later David Newman-Tucker developed the hinge. So if we combine the head impulse test and direction changing gauge evoked nystagmus and skew deviation, we can detect the stroke with 100 sensitivity and with a specificity more than 96%. But if you look at the result, in these patients with acute prolonged spontaneous vertigo for more than 24 hours, at the time the MRI was negative in about 10 to 20%. So the bedside, the test, including the hinge, are much more sensitive than the MRI during the acute period. So you should be very, delicate to evaluate the patients with vertigo to detect diagnosis these important disorders. But one caveat of hinge is that it has limitation in diagnosing the patient with ICA infarction, as I tell you later, because in ICA infarction, there's also a labyrinth sign damage. So head impulse test is already positive in patient with acute vasculopathy from ICA infarction. So hinge cannot detect ICA infarction in all the patients. So when the patient presents with acute vertigo and hearing loss, do not just count on hinge, and you need more evaluation, and head shaking may be one of those. So if you add head shaking, you can detect more ICA infarction. And this is a recent paper by Italian and group, and they adopted the balance instead of skew deviation. And I totally agree with this approach. So if you look at this algorithm, if the patient shows spontaneous nystagmus and it is a central pattern, the diagnosis is obvious. And when it is horizontal and unidirectional, you should do head impulse test, and it's negative is stroke, and it's positive, it is more likely vestibular neuritis. But be careful, I will show some cases later. And if the patients do not show the nystagmus, spontaneous nystagmus, check the balance, and the imbalance is severe, that is the sign of central lesions. Then now we are okay with vascular vertigo. We are all set with vascular vertigo. Let me introduce this old lady with multiple vascular risk factors with medication, who presented with acute vertigo and hearing loss and tinnitus in the left ear. She showed at that time spontaneous nystagmus beating to the right. It's totally, I'm sorry. And if you look at the head impulse test, it's positive to all three semicircular canals in the left side. So left posterior canal, right anterior canal normal. I will show again. So left horizontal canal is impaired, right normal, left anterior positive. So the head impulse test clearly shows that her left semicircular canal was damaged. All three semicircular canals were damaged at that time. And I scanned her, and the diffusion-weighted MRI were completely normal at the time. But if you look at the MR angiography, there's several stenosis involving the vertebral artery and basilar artery, and I admitted her to the ward, and I forgot to tell my resident to give her aspirin. I forgot at the time, and my resident didn't do anything, just observed her. And 4 days later, when I had a round, she told me that this morning I got some numbness on the left mouth angle and a little bit dysarthric. So I rescanned her, and the MRI beautifully shows the acute infarction involving the territory supplied by anterior inferior cerebellar artery. So what happened to her? So during the 3 days, there have been progression of isolated labyrinth sign infarction to full ICA territory infarction, because the internal auditory artery supplying the inner ear is a branch of ICA. So during the first presentation, she only had isolated ICA infarction, and then there's the thrombus progress to involve whole the anterior inferior cerebellar artery. So I reported these patients, and we found 3 more, and all 4 patients initially presented with just hearing loss and vertigo, and later they developed full ICA territory infarctions. So we reviewed all the patients with ICA infarction, and the message here is that the patients with ICA infarction usually present with combined audio or vasculopathy. So when the patients came in with both hearing loss and vertigo, you should think about the ICA infarction. But even the marked development of the brilliant development of brain imaging, there is no way to confirm the isolated labyrinth sign infarction. MRI doesn't show you the isolated inner ear infarction. This is the first case that documented the infarction of the vestibular nerve by diffusion-weighted MRI, just published online 2 days ago. So it's very rare. It's almost impossible to detect isolated labyrinth sign infarction. So please consider the possibility in acute combined audiovasculopathy, stroke, and when the patients are old or have any vascular risk factors, just treat them with the aspirin first, and then look and see what happens. Okay, that's the very important message. This is another patient with acute vertigo lasting several hours. She had hypertension with medication for 1 year, and she was admitted to our hospital by our resident, and at the time diagnosis was BPPV. So when I made the round, I asked her, do you have any ever history of transient vertigo? And she said, yes. I had that kind of isolated vertigo lasting several minutes for the past 2 or 3 years. And she was very wealthy woman, and she had her own the internal medicine doctors, and she tell him several times, I got dizzy, but the doctors only told her that it's okay. It may be from the hypertension or some kind of medication, so you don't worry about that. But when I listened that history, I immediately send her to the MRI room and get the imaging, and I found this tight stenosis of vascular artery. So what was the clue in this patient? What was the clue? Old age, hypertension, that may help, but you should be very careful to take history in the patients with vascular vertigo. The transient vertigo lasting several minutes strongly suggests vascular mechanism, if you can rule out the psychogenic or the migraine as an etiology. So that's another important, message. And in this 52-year-old man, recurrent vertigo 4 hours lasting a day, and just imbalanced when we examined him. He had multiple vascular risk factors, but imaging were completely normal. Normal diffusion-weighted MRI, no small vessel disease at all, on T2-weighted MRI. And if you look at the vessel at that time, even though there is a little bit of hypoplasia of right vertebral artery, the other vessels are completely normal. But I told him, you should have a stroke, even the imaging are normal. So I prescribed him aspirin, but he didn't take aspirin. He didn't believe me. 3 years later, he came to me, acute vertigo and sensory loss, some changes, and severe imbalance. And this time, the patient shows Wallenberg syndrome, acute infarction in the lateral medulla, and the vessels became worse over the period. You can see the stenosis in the left side. So in the paper by Miller-Fisher, he said that, the isolated vertigo turn into stroke in less than 6 weeks. So isolated transient vertigo lasting more than 6 weeks or months cannot be stroke. But it isn't true. As I show you the patients, it may last much longer than that. So don't believe this statement. Just treat and just evaluate, as I told you before. So even this is the papers on New England Journal of Medicine by Louis Kaplan, another very famous stroke specialist. He's actually the student of Dr. Miller-Fisher. In this paper, he stated that the dizziness are misattributed to posterior circulation ischemia. He still didn't believe that the isolated vertigo comes from strokes. And even in this paper, he stated that the isolated transient vertigo continuing more than 3 weeks are almost never caused by vertebral vascular ischemia. It's the view by the most neurologists and stroke specialists. But don't believe them. You just evaluate them and you treat, as I told you before. So don't believe others, you know. That's the message here. And this 54-year-old lady with also multiple vascular risk factors presented with recurrent vertigo lasting several seconds to minutes. Again, normal MRI, and on MRA, there's a little bit of suspicious narrowing of the vertebral artery on the left side. But at the time, we can't be sure whether this, subtle vertebral artery stenosis can cause recurrent vertigo. So we did perfusion-weighted imaging using CT. So if you can see here, he showed decreased perfusion in the left caudal cerebellum. So we proceed to angiography and found that indeed the stenosis in the left vertebral artery isn't matter at all. Instead, he had dissection of this posterior inferior cerebellar artery, which couldn't be detected on MRA. So the message is here, if you suspect vascular vertigo and the patient shows normal angiography or normal vasculature on MRI and normal diffusion-weighted MRI, consider the perfusion-weighted imaging to see whether there is any decreased perfusion, but without proceeding to complete the infarction. So at present, there is no way to confirm the diagnosis of isolated from vertebrovascular ischemia or stroke. So just treat them if you suspect vascular vertigo, and you can consider the perfusion-weighted imaging if it's available in your institution. But the result is a little bit unsatisfactory now for the posterior circulation, stroke, even the perfusion-weighted imaging. So this is my last message. So when you see the patient with isolated vertigo, you should consider the vascular causes and central pathology when the patients have severe new headaches and profound imbalance and normal head impulse test, skew deviation, and hearing loss, and the previous attacks of vertigo lasted only several minutes. And please remember that isolated vascular vertigo is a diagnosis of exclusion. In many cases, there's no way to confirm that. So evaluation, bedside evaluation is much more important than brain imaging, and give aspirin first and then wait and see what happens. Okay, thank you. I'm gonna take some questions or just proceed to, okay.